Really what I'm going to try to do is give you a very brief introduction to the clinical literature that actually both reinforces the need for value-based insurance design, but also highlights a little bit of what can happen if we don't think about that as we focus on value purchasing and cost control. So first slide, if whoever's controlling. This is just one iteration of the story we all know. As reform begins to take hold, we will start to even more focus on the costs associated with increasing access. And in the last year, the percentage of GDP covered by healthcare actually took a huge jump, largely because of the effects of the recession, but also because medical inflation continues to grow far in excess of the general inflation rate. So one of the challenges is in the context of where we're going next, healthcare costs will quite naturally take an even more central role in terms of attention now that we have greater access coming. What do we do in terms of serving those new enrollees and new beneficiaries? The other thing that's probably important from this slide, and there's plenty of literature behind this, even with that increased cost, there's still a vast amount of underutilization of necessary services, clinical services, and quite a bit of lumpiness in terms of which groups get which services that are appropriate. So again, healthcare disparities for low income, for ethnic minorities, for certain socioeconomic classes is alive and well despite the continued cost increases that we are all aware of. One interesting thing that will be coming out in the next few weeks in the literature, there does seem to be a closing of the gap of the quality of care delivered relative to the other G7 nations. So there's some glimmer of hope since the original IOM report that we're moving ever so slowly in the right direction on that front. However, the costs are actually still quite disparate and quite overplayed for the U.S. versus the other G7 countries. So the emphasis here is that as costs and cost management become even more important, we want to make sure we do it the right way and not the wrong way. And if you take anything away from what I have to say, there are some very bad ways to do cost management that can lead to very unintended consequences. And value-based insurance design is largely meant to be a smarter way to not only improve quality but contain costs. Go to the next slide, please. So essentially the physician mantra, the clinician mantra really, whether you're a nurse, physician, pharmacist, whoever, is do no harm. And one of the biggest risks that we have going into the next 3 to 4 years is as we work very hard to manage costs with a number of interesting and novel solutions like payment bundling or primary care medical home or different versions of consumer-directed health plans, different delivery systems. One thing that we can't afford to do, obviously, is make things worse in terms of quality, especially for enrollees, beneficiaries, patients, however you label them with chronic conditions. And really the value-based insurance design movement, as it's coined, is really an attempt to say, we can do this well, we can do this in a smart way, and we need to do it that way because the impact of doing it the wrong way are really pretty dramatic, and that's really what I'll focus on next. So first of all, a little note on what patients typically do or don't do and what it means in terms of their care and the cost. This is information that came out, if you look down at the, this particular reference, back in 2001. So the good news about presenting data that's old, and there's plenty of data since then that confirms this, but the good news is this isn't whipped up just to sort of be a positioning statement against reform or for reform. This is really just how patients behave. And up to 60% of chronically ill patients have poor adherence to evidence-based medicine. So move your thoughts to just sort of what's the right thing to do, what do doctors, what if other clinicians feel is the right thing to do. 60% of the time, patients with conditions where the right thing to do is obvious, or at least clear, don't do it. And that's not, and we've moved from an era where we call that compliance. The phrase that's really, I think, much more politically correct is adherence. And what that really implies is it's not all about patients knowing what the right thing to do is and then making some voluntary choice not to do it. It has a lot to do with their socioeconomic standing, their social situation, their home situation, their educational level, their understanding of what the doctor tried to communicate to them. But at the end of the day, there's a vast number of people that aren't taking the right medications, aren't doing the right follow-up, and that really has some very dramatic effects on cost and quality. You can see an estimate here of $100 billion in additional cost to the system, and probably more important is the thing that's in the middle. It's responsible for about 1/4 of all hospital and nursing home admissions. So these are staggering numbers if you think about it. So the takeaway from this is not just that it's a problem, but it's a problem whether or not costs are contained, costs are out of control, and the more we do to exacerbate the problem, the worse our cost picture is going to get very quickly. So that's the message on that slide. Next. And people can ask questions if they want. This is one study, and we've got a list of studies in this packet we're happy to share with you. Also, TriZetto will be issuing a pretty comprehensive white paper on this in about a week that will have literature references and pretty much everything that we're going to say today. So if you want that as sort of a handy reference, it's available. And we tried to make it very much an objective piece so you can use it as a reference guide. But this is a study that came out earlier this year. This is the same author that actually studied the effect of raising copays on the rate of mammography screening, which showed that higher copays actually lead to lower screening rates. This looked at, jump to the bottom, this is a 5-year study of almost 1 million Medicare enrollees over a 5-year period in 36 states. So it has quite a bit of validity regardless of where people are getting their care and what the conditions are for receiving that Medicare benefit. But long story short, doubling the copay to something as low as $15 or a little less than $15 actually had dramatically negative effects on enrollees in terms of their use of basic services like outpatient visits, and actually increased pretty dramatically the number of admissions to hospitals. So you may hear this a lot, but it's really true. If you change incentives in a negative way, even a little, a lot of people, even people with chronic conditions, actually don't take their medications, don't get to their physician, and end up in emergency rooms and hospitals. So the whole point of value-based insurance design is to be smarter about those changes in the incentives so that you're targeting the right people with positive incentives and potentially turning off the behaviors that lead to unnecessary care. Next slide, please. This is another study from Goldman that came out in 2004, and it's often quoted. But this was a study of patients and what happens if you had higher copays for certain whole list of medications. And the takeaway here is the same. If you're talking about medication use, it actually gets worse if you raise copays. And probably the most important thing is these are not trivial meds. These aren't discretionary meds. These aren't designer meds. These aren't, lifestyle medications. These are hypertension medications, medications for high cholesterol, medication for diabetes management. Now, I will say in this study, patients with chronic conditions didn't have as dramatic an effect as patients in general, but they still, anywhere from 8 to 15 to 20% reduction in the appropriate use of medications when their copay was increased. And obviously this led, if you can look at that last bullet on the right, an increase in annual ER visits and an increase in hospital stays. So if you want to get to the root cause, at least on the consumer side, of what's going to drive the right kind of behavior, you've got to start talking about kinds of incentives, positive incentives that lead to behaviors related to clinical outcomes. Next. So this is it, just in terms of takeaways. Underuse of important services exists regardless of the level of healthcare costs. So that's pervasive in our healthcare delivery system. It's based on a lot of factors, some of them under physician control, some of them related to how the system is organized and structured, some of them related to the member. Blunt cost management without attention to quality can really backfire. So all of those studies are really meant to tee up, and there are many more, the fact that you do the wrong thing and it's going to get a lot worse, a lot faster than people want. The good news is that if you do the right thing in terms of positive incentives for the kinds of clinical behavior, it works in the other direction just as dramatically. So I think the positive story out of this is a little bit of thought about how benefits are structured and how incentives are delivered can go a long way. In my own experience several years ago, I remember I was working for a plan at the time, and there was a proposal to actually make office visit copays $25, to offer a plan design where it would cost $25 to go to the office. And at the time that sounded a little bit aggressive, but for people that want to buy that kind of plan, maybe it made sense. What people didn't think of is that if you needed kidney dialysis, you went to an office, as we defined it, about 3 times a week. So you were exhausting your deductibles and your contributions and spending $2,000 or $3,000 or $4,000. And 10 years ago, that seemed like a lot of money. I mean, we're now in an environment where many of us are part of health plans where the expectation is we'll spend thousands of dollars before the benefits even kick in. So think about value-based insurance design as a way to approach that challenge and to really be smarter. And so the last point I want to make is, work to manage what you want to improve. If you want to improve the cost picture, focus just on the cost, and guess what? You'll get all kinds of messy, unintended consequences on the quality side. If you want to improve value, which is the ratio of quality to cost, then you have to focus on it and you have to manage it directly. And the good news is there are many, many ways to do that now, and Gail, who leads our value-based insurance design group at TriZetto, is going to go through a few slides to highlight how people can get there now, that it's not some sort of pie-in-the-sky technology that hasn't been developed. So I'll stop there. Any questions before I sit down? Is that exciting?